Hello, my name's Kim Eagle. I'm the chair of the GenTAC Alliance, and I'm delighted to be giving you a talk today on aortic dissection, the current state. This slide, I think, illustrates our current thinking about how clinicians should approach suspected aortic dissection. And the best test is a great history and physical, along with an assessment of the ECG and chest X-ray. And the history needs to especially think about past medical issues that would predispose the patient at higher risk, like Marfan syndrome, family history of aortopathy, known aortic valve disease, recent aortic manipulation, known aortic aneurysm. The present history is most notable for whether there is thoracic pain, which typically is described as very abrupt in onset, instantaneous basically, severe in intensity, maybe ripping or tearing. The physical exam is very useful, and we're especially looking for a pulse deficit or blood pressure differential in the arms, or focal neurological change. That can be stroke, ischemic spinal cord, things like that. We're looking for a new murmur of aortic valve insufficiency, which is critical. And some patients will present with extreme hypertension or hypotension or even shock. Obviously, the EKG is helpful if there's no ischemia or MI, but sometimes patients with dissection do have abnormalities of the ECG, and unfortunately, a small percentage of them actually have both a dissection and an MI caused by interruption of one of the coronary ostia from the dissecting process. The chest X-ray is also very helpful, looking for the possibility of a wide mediastinum. Next slide. This slide illustrates how we can use those key factors from the history and physical to make the diagnosis. And you'll see on the left side, high-risk conditions, Marfan, family history, known aortic valve disease, etc. In the middle, high-risk pain features, which we just talked about. And on the right, high-risk exam features. This is a study of over 9,000 patients with dissection. And we were asking the question, how often did patients have one or more of these categories of markers? And you'll see that only 9% of patients had none of them. So 91% have one or more of these. 80% have high-risk pain features. Almost 40% have a high-risk exam feature, and almost a third have one of these high-risk conditions. So if you look at the 9% who didn't have any of these, often they presented with painless dissection with a stroke or coma, something like that, and ask the question, well, how often did their chest X-ray show something? It was half the time. So half of those patients might have been identified by a wide mediastinum. So this slide tells me that if you do a careful history and physical and a chest X-ray, and you're ascertaining these features, we should be able to diagnose 95 to 96% of these patients. And unfortunately, right now in this country, around the world, it's thought that we're missing far, far more than 4 or 5%. Next slide. This slide illustrates the demographics of patients with dissection over 3 tertiles of the IRAD registry. And most notable, I just want to talk briefly about a couple of things. Recall that the average age of dissection is about 61, 62 years. 2/3 are male. About 2/3 are type A dissection. Hypertension is almost ubiquitous. 80% of patients have it. And then let's ask, well, what about some of these rare conditions that underpin dissection? Marfan syndrome is responsible for about 3 to 4% of all patients with dissection. Cocaine use, 1 to 2%. Peripartum state is about 1%. Familial aortopathy is more common. It looks like about 10% of patients currently are diagnosed with a familial tendency to dissection. And I think that number is going to grow as we get better with genetic testing and screening family members who might have had sudden death and we assumed it was something else. Smoking, of course, is a risk factor for dissection. Almost a third of patients have that. Next slide. If you ask the question, wouldn't it be nice to have a biomarker for acute aortic dissection? The answer is yeah, we have one already. D-dimer in study after study after study has shown to be a highly sensitive biomarker for dissection. And this study, which is now over 10 years old, we showed that D-dimer, especially in that first 6 hours, this graph on the left, is remarkably elevated in patients who have an acute aortic dissection. It's probably about 98%. And the 2% who don't have an elevation probably primarily have small intramural hematomas. So this clotting biomarker is very sensitive for dissection. I think we should be using it. Often we also realize, of course, it's not specific, and it can be elevated in acute pulmonary embolus or a myocardial infarction with a large clot burden. But I think that biomarkers are going to be very important in early diagnosis. I think D-dimer should be used more than it is now. And we're looking feverishly for a more specific biomarker that could be added to this in a platform. And I'm hoping that fibrillin-1 fragments might be that biomarker. That study is ongoing by people like Scott Lemaire and others. Next slide. If you ask the question, how's the world evolved in how we use testing to identify dissection? This slide from the IRAD registry illustrates a couple of points. First of all, CAT scanning is by far the most common first test used in the world, and now it's up to about 91%. And from the early days of IRAD, 1995-ish to start, TEE has steadily fallen from almost 30%, where it was the first image, to now less than 10%. So the CAT scanning is virtually always available in emergency departments now, and it has stood the test of time in terms of being the diagnostic test that is first used by clinicians around the world. Next slide. If you look at acute dissection outcomes with type B dissection, this slide illustrates that the overall mortality over time has fallen from about 10% in the late 90s to less than 8% in the last 5 to 6 years. And of course, endovascular management has been used in about 10% of patients and has really replaced a lot of the surgical management, so that patients with complicated type B dissection who have anatomy favorable to endovascular therapy and are having things like malperfusion, they're getting endograft therapy more and more. If you go down to the bottom of this slide and look at the 5-year survival, it looks like over the past 2 tertiles, the survival got better with type B dissection. And this has been true, especially for those managed medically and the smaller number of patients getting surgery. And I think endovascular therapy has had a big impact in this area. Let's go to the next slide. I think this slide illustrates one aspect of this that might be relevant. The top part of the graph looks at time from admission to diagnosis. And for type A dissection, this has really not changed over the last 20 years. It's about 2.5 hours. What has occurred is the time to diagnosis in type B has improved. And I think what was going on early was that we were using TEE more. And as you know, TEE has a better chance of missing dissection in the arch and the proximal descending aorta. Now that we're using CT much more, I believe that is translating toward earlier diagnosis, which we see in the IRAD registry. And I just gave you a slide suggesting that for type B, mortality may be going down. And I think part of it is that we're finding the beast earlier and making interventions when we need to. The bottom part of this slide is very sobering, for me at least, and it asks the question of patients who come with a dissection, whether it's type A or type B, how many of them have really large aortas anyway? And the answer is, if you look at type A, over the 20 years of IRAD, over 50% of patients who have a type A dissection do not have an aorta that's larger than 5 centimeters. And a significant percent have aortas that are actually normal or barely enlarged at all. And this is after the thing is dissected, where we know it grows like 3 or 4 millimeters. And for type B, You know, we've used a surgical cut point in the descending aorta, at least some surgeons, of 6 centimeters. 90% of patients who dissect in their distal aorta have an aorta smaller than 6 centimeters. So this slide illustrates, for me at least, the thing we need to do, and that's better science, to understand these patients who are having dissection. And we need to get over the notion that all dissections are related to aneurysms. They're not. They're related to weakening of the aortic wall by various processes, but not necessarily an aneurysmal process. So we need to get better. Next slide. This is probably the most important slide I'm going to show today, and it's in some ways the least scientific. This is a survey we did of a number of survivors of dissection, just asking them, what is survivorship like? And it's not pretty. 40% of the patients said they were disabled completely from work. Almost 3/4 had stopped having sexual relations at all. A third had significant depression. A third had anxiety. And almost 3 out of 4 said, we need clearer recommendations. I'm not getting information from my doctors and nurses about what I can do. What's my life like? So the survivorship question is big. And I am committed to the process of developing a much more robust scientific framework for how we promote survivorship, including mental health, physical health, sexual health for patients who survive this devastating illness. We need to do better. The signal is there. We need to go after this. Next slide. I want to thank all of the IRAD centers who've contributed to the data that I've shown you. There are currently 59 centers around the world, and we've studied 10,500 patients over the last 25 years. Also want to thank the colleagues in the GenTAC registry and then now the Alliance, and especially delighted that the Marfan Foundation now will be powering the GenTAC Alliance going forward. And of course, a thank you to the National Institutes of Health that funded the GenTAC registry, then the Alliance for 3 years, and has had such a profound effect on our knowledge because of their investment in the science. Thank you for listening. I look forward to our dialogue.